Good morning. This is time for our meeting and we have a quorum. We will start the meeting. Agenda item number 1. Papers issued since the last meeting. There were none from the Secretariat. Agenda item number 2. Items for discussion at the next meeting. There will be a next meeting to be held on April 10th, Friday, 10:45 a.m., and the administration has suggested 2 items to be discussed: preparatory work for Hong Kong Regulatory Management Center for medication and medical equipment, and legislative proposal for uniform packaging, design regulation for traditional smoking products, and latest progress for duty stamp label system. Yes. Mr. Xu Kafai. Thank you, Chair. Concerning the item on packaging and label for duty stamp, I think we should have customs to come join the meeting because they would be able to provide information on processes. Any other opinions? No other opinions. Yes, we will invite customs as well. We go to the third agenda item, latest progress of primary healthcare development. Apart from the administration's paper, we also have the background brief prepared by the Secretariat, and we have 3 submissions from the Hong Kong Physiotherapists Union and professional optometrists for the item. So let us have the administration come into the room, please. Now, today, representing the administration is Dr. Cecilia Fan, Under Secretary for Health, Eddie Lee, Deputy Secretary for Health 2, and Dr. Pang Fei Chow, Commissioner for Primary Healthcare, Health Bureau, Dr. Zheng Wai Lun, Director of Strategic Purchasing Office, Health Bureau, and Dr. Christy Lam, Assistant Commissioner for Primary Healthcare 3, Health Bureau, and Dr. Tony Ha, Director Strategy and Planning, Hospital Authority. Now, if you want to speak, members, would you please press a button? Yes, please go through the paper. Greetings, everyone. Greetings, Chairman. We will be going through the latest progress of primary healthcare development. And in particular, we will be talking about the co-care network as a main focus for next phase development and its implementation. Now, since the implementation of the primary healthcare blueprint, we have comprehensively coordinated and managed primary healthcare services in public and private sectors, and also we have set up the Primary Healthcare Commission, and also in the 18 districts set up the centers with over 100 service points for now. And also we have set up a health network. And at the same time, there are different screening and healthcare management schemings, and also there are underprivileged groups, the services provided to them. And in particular, there is progress on the co-care for chronic diseases, and we already have 210,000 citizens participating, which is overshooting our original target for completion. So that is early detection of the diseases and also to raise the indices for their health. And in the longer term, we want to be able to cut costs on such medical expenses, and we would want this to be part of the regular framework so that this becomes a service for health-centered approach. And also there is a scheme for and also a guidance for healthcare. So this would coordinate cross-disciplinary cooperation, and this is a very important basis for our transformation. And on this basis and in this direction, we will be deepening the systems coordination and co-care as well as cross-disciplinary coordination and cooperation. And there are 3 main prongs in that regard, and that is a network for co-care, and in particular in this is about the whole person approach. At present, the services are disease-specific or focus on special sectors of the population, and through this network, we will be able to integrate all the primary healthcare services so that there will be lifelong experiential support. And also, the centers will be the points of service provision so that there will be personalized as well as standardized health services. Now, this co-care network would include the 3 highs and hepatitis screening, as well as gradually women and aged persons service. And for chronic diseases, we will be covering more of these, and for different age groups, there will be whole life cycle service and coverage, and family medicine and also underprivileged sector support will be increased. And also, there will be a deepening of cross-disciplinary collaboration. So the DHCs will be the primary healthcare resource hub, and there will be a better referral system, and there will be also standards set so that the DHCs will be the gatekeepers, and also the guidance will also be transformed into a list of names and references so that the conditions and also the monitoring and coordination of the healthcare services can be improved. And also for the different diseases, there will also be a reference guidance overall. And in July of last year, as we know, the legislation had already been passed to further promote this interdisciplinary or multidisciplinary approach. And there are 3 such hubs which is already in operation and will continue to monitor them. And at the same time, there will be more community services so as to promote the service for medicine, and also for there will be a one-stop shop for a platform for health and medical service, so that there will be further coordination among the different disciplines for collaboration and also for technical support, and also for mental health and the old age care. Medical services will also be enhanced. That is the progress report. We welcome any questions. Yes. We also have members from the health panel to join us. So now we have a list of members who would want to ask questions, and they are Chan Pui Leung, Peter Douglas Kuhn, Christine Fong, Kingsley Wong, Chen Wing Kwong, Chen Hock Fong, Yang Wing Kit, Shiu Ka-fai, David Lam, and Duncan Chu, and myself. So 4 minutes, question and answer. Chan Pui Leung, please. Thank you, Chair. The paper has pointed out that there is primary health care to be provided for co-care network, so that in the future there will not be any disease-specific direction in the future, but it will be a lot more coordinated. Now, for this kind of standardized ongoing health monitoring on this system, I would like to know concerning the standards of screening. Will it be a specific disease-specific screening, or will it be a coordinated approach? And what about the co-payment arrangement? Will that be changed? And also for the 5-year, the first phase of the 5-year, 700,000 participating and $2.5 billion budget DHCs. We now have 10 of such, and also 8 the DHCEs. And I would like to note these DHCEs, which are District Health Center Expresses, when will they become DHCs, that is District Health Centers, and the relevant residents where there are no DHCs in the area, how do they participate in the co-care network? And this 5-year, 700,000 participants target, is it too conservative? Because we see from previous scheme at initiation there had already been 210,000 participants. How did you come up with this target, please? Thank you very much, Mr. Chan, for the questions. There are a few questions there. First of all, concerning the standards on the network, well, the service providers will have their standards, and we, our administration, will have the standards as well. So my colleague will answer that question and supplement. And concerning the DHCs and DHCEs, well, for that question, I will say that there are already 10 DHCs and 8 DHCEs, and in Kwun Tong, Wan Chai, and Sai Kung, and the northern areas, there will be further centers to be completed, and there will be more completed. And also Tai Po, Sha Tin, the outlying islands, and Kowloon City, we are also very proactively working on them, and we'll be coming to the LegCo for extension and also for funding, and we want them to be transformed into district health centers. Right, the other question. Yes, Dr. Chan. Yes, so in the reference that we are formulating, there are different diseases with certain guidances and standards, and there will be different treatments. Let's say, for instance, there will be a risk-centered approach and disease approach for the elderlies, and for hepatitis, for example, or liver diseases, we will be more specifically focusing on the persons of high risk in these diseases. So there will be more a disease-specific approach. And yes, there will be a this will be basic and fundamental to the network, and we are now discussing with the relevant parties. As for co-payment for the hepatitis B scheme and also women health tests schemes, we are, and relevant schemes, we are doing an overall comprehensive review so that the relevant doctors and the medical personnel can have a better cross-disciplinary service approach. Now, as for the 700,000 target, we see that there are a lot of elements to be coordinated. For example, the concepts for primary care will have to be promoted, because we see that for the Hong Kong population, there is still a lot of work needed for them to understand this concept. And also in the process, we need a lot of professionals as well as medical doctors, that they need to follow certain medical procedures to provide the service. So we want the estimate to be more accurate to see how many members of the population can participate in this scheme. Next, Peter Douglas Kuhn. Thank you, Chair. Well, first of all, we thank the administration for providing pretty good primary health care. And as the population ages, I want to know from the government, in your assessment for the future, will there be further information that you can provide for us in the next 10 years for people over 80 years old, it will be over 1 million or 1.2 million. At the end, for the elderly, they will be using more public healthcare services. In the initial stages, I can understand that the administration is putting in a lot of efforts in building the DHCs, etc. Now, for certain elderlies, they will have certain pain diseases. And I have actually discussed with the administration, and I do see certain services which are not well coordinated because there are a lot of diseases which involve pain for the elderly. For traditional Chinese medicine, it may be one of the health solutions, but I would like to hear from them how this will not overburden our primary healthcare system, because I often see that the referrals for these elderlies, they very often go back to the original healthcare providers. So what is the service for the elderly, please?
The government is very much concerned about the situation. Therefore, in our healthcare reform, we are moving in that direction. So, as mentioned, we believe that in the future, elderly people aged above 80 will increase in number. Therefore, we advocate to early prevention. So, if someone is 75 now, so in the coming years, we hope that they can engage in more preventive work, and younger ones can have more time for prevention. That's important. When you have stroke or heart attack and is hospitalized, but if you can. And people may not know or be aware of their problem or having diabetes or heart issues beforehand. If you properly manage cardiovascular diseases, then 80% of the early deaths could be prevented. So our plan is such that the PHC Commission will help people at different stages in their lives. And for elderly people, in this fiscal year, in 26-27, we will by stages integrate our district health centers. The Department of Health now had district health centers in 18 districts and have a cross-disciplinary team to serve elderly people aged 65 or above. But in the days ahead, because of rising demand, in order to effectively cope with the situation, we will launch new models. And under the model, the district health centers can provide personalized health risk services and health education services as well. So we also will increase the service points to serve more people. I'd like to ask Dr. Pan on the issue of physiotherapists, answer Reverend Kuhn's question. Aging, well, in dealing with it, this issue of aging, we need the support of various service providers. So therefore, last year, with the amendment to the Allied Profession Ordinance, Health Care Professionals Ordinance, we have made the arrangement for introducing new arrangements face by face. And I know the physiotherapists will also act on addressing pain issues, and registered Chinese medicine practitioners in terms of dealing with pain issues, they will be entitled to provide more services along others. And we also aware various management committees, in light of the latest legislative amendments, also have made arrangements for first contact physiotherapists arrangement. So as we collaborate with different sectors, we do need to open the way for more inter-referrals. And HA will issue various guidelines, and on the basis of the guidelines, we will try to engage more sectors, and through various discussions and reaching consensus, we will by stages launch the various arrangements. And we launched the first part already to address common diseases. And by now, the sectors are actively training first contact physiotherapists. The number is limited, but we do hope that the profession can increase the pace of training of potential physiotherapists for first contact assessment. We hope that in the coming days we can keep discussing, collaborating with various sectors so that we can absorb more experts' opinions and increase the synergy effect. And we believe that as society ages, we can provide the help needed. Next one is Christine Fong. Thank you, Department of Health, for promoting the CDCC, covering or targeting people age 45 or above, and with the target population of 210,000. I do welcome that. You have a 5-year plan to raise the target to 700,000 at a cost of $2.5 billion. I'd like to ask, say, for the age of 65, the threshold of 45, have you considered lowered this threshold to a lower age? Because for 3 highs, it's not that if you're 40 then you have no 3 highs. Particularly for people living in urban cities, we have eye diseases like dry eye disease or other tooth issues, or we have sleeping problems, which actually may require people to seek consultation with Chinese medicine practitioners. And now you've brought in the scheme to include screening of hepatitis B and breast cancer for women. Department of Health has done very good in screening for women, including pap smear test. You tend to adopt the principle of whole person assessment. Early on in Ma On Shan, as I mentioned, Ma On Shan, you are considering on the locations for various district health centers. Have you decided on the locations now? And also on drugs. I know that your community drug formulary is intended to cover 400 types of medicines in the community pharmacies, including aspirin. And the public do want to have better quality medicines in the formulary. Would you move in the direction of reducing the burden of medication on the public? Under Secretary, as for community pharmacies and medicines, I will ask Dr. John to answer. As for the entire PHC Commission, it will help people at different stages of their life, and Dr. Pan could answer that or give you more information. And 2 things. Just now you mentioned that our CDCC reached our target ahead of schedule. The originally 3-year program already reached our target of 210,000 by February. As for the age threshold, it's not we're not working depending on the age alone. We need to consider the risks and the prevention needed at each age. So therefore, we are going to incorporate various services for women and elderly people based on that concept. And as for locations of district health centers, according to our blueprint, we have reserved locations in various districts for the long-term development of primary health care. So we'll study how in various districts we can have proper planning to develop healthcare facilities and coordinate with the various other facilities in the same district. Dr. Pan could supplement. In the past, under the pilot scheme, we used age 45 as a benchmark because scientifically speaking, the risk will largely increase after the age or beyond the age of 45. Now we've entered the co-care network stage, and therefore, besides the age, we will also make adjustments based on risks. For example, hepatitis B, we used the 1988 people born in 1988, and then as one of the criterion, and at the same time, with the We also select appropriate patients to enter the network using data from the FMCs. So we have begun testing based on the chances of risks. So we will see how we can use a risk-oriented concern or consideration as one of our threshold. On women's health, at the FMCs, we have begun some women's health services, including pap smear test. So in the past, we tried to, in the community, when we were to provide such services, if we were to involve family doctors, what sorts of adjustments might be needed. So at the next stage, we'll actively explore, for example, we can involve community family doctors more. And I can still recall, Ms. Fong, you mentioned Ma On Shan. In Sha Tin, the availability of space is limited. And but there's a maternal hospital in Sha Tin, which will vacate some space to provide services of DHCs. In Ma On Shan, we are using mobile service points to provide support. We'll actively consider how we can provide better services in that district. Thank you for your question. Dr. Zhang, thank you for your question about the community drug formulary. The purpose of that is to help people involved in the co-care network. They can, through the mechanism of the community drug formulary, have most of their medical needs covered at an affordable cost compared to going to the private market. Patients will save a lot more financially. As for through what channels can people use the drugs in the community drug formulary, they can access them through prescriptions by the family doctors, or patients can choose to join community pharmacies which have joined our CPP. So we want to take reference from the development of primary healthcare and not so much follow the direction of separating medical consultation and medicines. We just want to give the public more choice in obtaining the medicines they need, and also help foster collaboration between family doctors and community pharmacies. We do hope that by the second half of this year, the applications of drugs can be, on the basis of the community drug formulary mechanism, can be available to the public. We believe that more than 100 types of medicines will be covered. And as the primary healthcare develops, as more diseases are covered, gradually, yearly, we will enrich the community drug formulary. I think in the long run, hundreds of medicines could be offered. Thank you. Next one is Kingsley Wong. Thank you. Well, if you're sick, you need to spend money to seek help and try to prevent further deterioration. So the co-care network, the pilot scheme, has worked with more than 210,000 participants, and this can help prevent 11,000 death cases and save medical expenses up to more than $2 billion. So now you have gathered the experience, you can help promote the service to high-risk populations so that more can benefit from your scheme. Occupational health in Hong Kong is another issue. Based on the Labour Department statistics in the past decade, each year there are about 150 employees who actually die, not because of accidents or occupational diseases. Often, people are not aware of their health problems, like security guards in 2024. 48 died. Drivers, 10 died because of health issues. This is really a good justification for promoting the chronic disease co-care network. Security guards. Actually, there are 130,000 who are aged 65 or above, making up 1/3 of the total number of security guards. So have you, targeting these professions, carry out some screening? Our labor union very much support screening because that can take care of the health of the workers, and also it can help save our future medical expenses. Under Secretary, thank you, Dr. Wong. I do thank you for expressing your support for collaborations with us and providing useful information. We do act, as you have suggested, in the niche. As we sum up our experience, male participation is less than that of women, so therefore we have a theme to involve more men in helping improve their health. So I think Dr. Peng can introduce to you our key work ahead. Yes, thank you. This year, since we found that certain professions, the employees in those professions need more support with their health, we have begun collaborating with Labor Department and relevant sectors, or discuss with the security guard professions or professional drivers unions to discuss what we can do. We know that employees in those sectors have constraints in their work, or there are some cultural issues that we need to look into. So we hope that within this year, hopefully through a simple approach, we try to promote health messages to employees in the sectors and encourage them to join our health schemes and establish bridges with family doctors.
And also to see how our services can be extended to them in a more flexible manner so that they can be followed for the long term. So these are the things that we would want to work on in the coming years, and where we have progress, we will come to you for reports. Now, I'm wondering whether you have considered working together with the trade unions in the different sectors to collaborate together in this direction. Thank you, Chair. There is one item this year which we are in the preparatory stage for, and this is one such. And we will be talking to the industries, unions and associations to discuss this. Thank you very much, Mr. Wong, for the suggestion. Right. Chen Hockfeng. Yes, I would want to take this opportunity to commend the administration on a lot of initiatives in primary healthcare development. Now, for TCM, Chinese medicine, we know that it is very effective in preventive services. But on the other hand, we Chinese medical practitioners feel that the relevant policies seem to be all talk and no substance, because for the co-care network, for instance, for the chronic diseases services, there doesn't seem to be any involvement of Chinese medical or medicine to really speak of. And basically, I would like to know in the future, what are some specific measures that you will have to increase the role of traditional Chinese medicine in the primary healthcare development. You also mentioned in the paper for co-care network that there will be more collaboration with Chinese medicine for women health and also elderly health. What are some of the indices in that, please? And what are some of the targets? And would you consider for certain diseases which have been shown to be effective for Western and Chinese medicine co-treatment, would you be putting those into your list of chronic diseases? And also, for many of the Chinese medicine treatment centers, there is a long queue waiting for service. But at the same time, there are a lot of private practitioners for Chinese medicine as well. Have you considered private-public coordinated services? Have you also thought about having one person, one Chinese medical practitioner scheme so that Chinese practitioners or Chinese medicine can play a bigger role in primary healthcare? Well, thank you for the question, Chair. Chinese medicine is a very important component of primary healthcare, and we also have a developmental blueprint for Chinese medicine, and we will strengthen Chinese medicine in primary healthcare development. And Mr. Lee will be going through the strategy and also the policy direction in this regard. For Chinese medicine in different venues, we have discussed this at length, and Mr. Chan, Honorable Mr. Chan, had always been concerned about its role in primary healthcare. Just now, we mentioned for Chinese medicine practitioners, the question was that the role is not very large in primary healthcare. We agree that there is room for further expansion of the role. But in the past few years, the role had been expanding. For example, we have mentioned in the 18 districts, there are these centers and also Chinese medical treatment centers, and they have increased from 600,000 to 800,000 chips. And also we have pilot schemes and award pilot schemes for Chinese traditional medicine, TCM. And through the health vouchers, the TCM had also been extended to more people in Hong Kong. Among the many disciplines that we have, TCM is already the highest in terms of expenses under the voucher scheme, just next to Western medical practitioners. We also understand that there should be further extension of TCM services, so we will prioritize the for women health under the DH for women health, for in particular menopausal TCM services, for instance. We would want to enhance that. But at the same time, we want some clinical directions and guidelines and before we actually do that. But this is definitely something we prioritize, menopausal service for women health. Now, for the elderly, as mentioned earlier, there are already some collaborative services which are involving TCM, and they are for treatment of pain issues for the elderly. Physiotherapy had been selected, perhaps not really prioritizing TCM, but there seems that there is room for further education and promotion in the sector for more use of TCM for pain-related services. Next. Yes, Chong Ho Fong. Chair, I think prevention is very important. So before a major disease is detected, that there should be prevention first. According to my understanding, there is a hub role for the DHCs, the district health centers. So they are the pigeonhole, if you will, for distributing the cases. But a lot of people in Hong Kong, the general population, do not understand the DHC's services, what it provides, because we are talking about chronic diseases and co-care. So how can we actually promote this among the population so that the population will understand that the DHCs are hubs where they can get medical information and also for other services? That's the first question. And secondly, you will have referral for family doctors. In terms of fees, are there limits? So as to ensure that it will be not overburdensome financially for the population of Hong Kong. Let's say $200 Hong Kong per case, but the family doctor cannot charge over that or a certain amount. Only then will you be able to ensure that the population will be going to these intended doctors. We also know that the elderly are using the vouchers. And the doctor would ask, do you have a healthcare voucher? If they say yes, then the private doctor would charge $400. So $200 from the healthcare voucher on top of the $200 consultation fee. So the benefit is going to the private doctors. What's your response to that? Now, we also see from your paper that for the 3 highs and also high blood sugar, there is some 50,000 which have been detected. So what is the result? So that's a screening results, but what do you do after that? What is the total expenses involved? So in the future, we would know what kind of services we should be providing. Well, Ms. Fan? Well, Chair, concerning the role of the DHCs, we can look upon it as follows. We hope that the population would use the DHCs as a first point of approach, and we would tell them what they need at that juncture in time, and we will match them to the healthcare providers in the network. So it has a very strong role in linking the population with the network, and we provide the resources to the service providers as well. We want more people to use this system, so there will be a major promotion in this regard. Dr. Pang will be talking about that. You mentioned just now concerning the treatment stage. How many people go into the treatment stage? Well, actually, the people will have to first participate and register, and then they will have to bring go for blood sampling, and then there will be a report engendered, and we find that over 40% of the people for blood lipid, blood sugar, etc., who will be invited for further treatment. Dr. Pang will talk about that as well. Thank you, Mr. Chan, for the question. We understand in building a new system, we need a lot more publicity so that the population would know the benefits of it. So in the coming year, we will go through different media to formulate promotion strategies, and through different visible publicity programs in the MTR stations and major promotions via the different media, including social media. We want to be able to penetrate to every aspect of life of the Hong Kong population, and there will be further explanation sessions for them so that they thoroughly understand the roles of the family doctor and the DHCs. And yes, we'll be putting in more efforts to educate the people and promote this. We understand that there are difficulties. People at large, we want them to understand what they can do for disease prevention and treatment. Now, Mr. Chan just now asked another question concerning private medical practitioners and their fees. There are 2 prongs to it. One, adding and increasing transparency. Those medical practitioners or service providers who participate in our schemes and network, the co-payment portion for them will have to be transparent, and also they will receive an SMS after each consultation to ask how much they have paid under the co-payment scheme so that we know the actual situation, how much the Hong Kong person had paid for the consultation or treatment. For family doctors and the network, there is a matching, and this is very important. The reason why we emphasize cross-disciplinary is because under eHealth Plus, through membership system and through agreement, there can be monitoring of this cross-disciplinary service. And also, we would be able to know for the citizen concerned which particular discipline they should access. And also there will be transparency for co-payment. But of course, we provide flexibility for the communication between the patient and the family doctor. If the patient wants to choose other disciplines of service, he will have the freedom to do so. Yes, there will be more monitoring, regulation, and also communication with family doctor services. Now, as for the patients who are found to have chronic diseases, over 90% of them still have family doctor continued consultation. We know that they're still getting their medicines from the family doctors, and we know the times because every year we have 4 to 6 subsidized sessions. So we will know how they are proceeding in terms of treatment and also getting the drugs. So this is a feasible way forward. Thank you for the question. Next, Yang Wing Kit. Yes, I would want to affirm the primary healthcare work. I would want to ask a question about community dental service. Now, under the on the 1st of January, the elderly dental service had ceased. So the elderly are going for community dental service now. But it is not even in terms of service. For Kowloon Central, for example, the service is not sufficient. In Kowloon City, there are 6, and they are in Kowloon City and To Kwa Wan, but not in Kai Tak, not in Ho Man Tin. What I'm trying to say is if people want to have neighborhood service for an elderly, let's say in Wong Tai Sin, Chuk Yun, the elderly person will have to walk to Chiwan Shan, up the mountain, up the hill, before he or she can get the dental service. So have you considered for NGO dental clinics, you specify where they set up shop, in what districts and what neighborhoods, so that the elderly do not have to cross districts to get the service. So I think this will be more convenient for all concerned. And also for the community pharmacy program, there are already some pharmacies, but it is the same issue that they will have to be more evenly distributed among the districts.
So we do hope that you can implement it on a district basis, and that would be very helpful to the elderly and others. And also on the district health centers in Kowloon City, you're promoting it actively? First of all, I'd like to find out about the progress. When do you want to see the district health centers be commissioned in Kowloon City? And also, as for its location, it needs to be somewhere with convenient transportation. The District Health Centers Express nearby is not really well located because it's in the factory area. So if you want to have more people using the DHCs, then you need to really think carefully about its location. Kowloon City has a population of 400,000 plus. If the center is not in a convenient location, residents will not go there. The most ideal location is somewhere near the MTR station, because otherwise residents would not go there, but rather have a body check at a private clinic instead, so as to see if they have any hidden diseases. So I hope that through your centers, more people can have more preventive treatment. Undersecretary, you have 3 views, and they're well noted. May I ask Deputy Secretary to explain about the dental assistance program, and Dr. Zheng on community pharmacy can give you more ideas. Thank you. Briefly, about the community dental assistance program. When we prepare for the program, NGOs were very enthusiastic. But then, because of lack of manpower, NGOs were concerned that they may not be able to hire enough staff. Therefore, There were enough points offered, but not as being able to have comprehensive cover. So at the next stage of the program, our staff will be increased, and NGOs are encouraged now to expand their dental clinics. At the next stage, when we launch a program again, I'm sure that number of participating NGOs will increase and more comprehensive services will be offered. As for community pharmacy program, it is a community-based approach that is across 18 districts in Hong Kong. In each district, we want to have at most 5 pharmacies under the pilot scheme. This year, the first tendering exercises had reached the deadline. We are carrying out assessment now. By the end of this year, we expect that 4 out of the 18 districts would have a certain number of pharmacies. By the middle of next year, end of next year, all 18 districts will be covered with a certain number of community pharmacies. The maximum is of 5. It's not the ultimate goal. Following the pilot scheme, after review, if there are appropriate locations, you can continue to expand the program. Next one is Shu Ka Fai. I'd like to compliment the Health Bureau for the effort in promoting primary health care, but you can do even better. So I've got 3 questions. I received from the Hong Kong Physiotherapists Union's Chairman Ouyang Kin his viewpoint that for physiotherapists, there's been approval for the absence of referral, but the latest decision is that it will only cover osteoarthritis of knee and low back pain. So can you explain why only those 2 areas will be covered? And also you've got a submission from the Hong Kong Optometrists Society. They want to join in the primary healthcare system. Quite a number of elderly people, if they can cure their eye diseases at an earlier stage, then they would not become or succumb to more serious eye problems later on. So if you have pharmacies involved or have early screening, then and also improve education, then that can benefit more people. And also you talk about the elderly voucher plan in paragraph 52 of the paper as mentioned, the voucher plan. And for pharmacies to enjoy the usage of elderly healthcare vouchers, then better quality medicines could be prescribed. So I hope that the elderly healthcare voucher scheme can be used under the supervision of pharmacies in pharmacists. Thank you. You mentioned the first contact referral by the physiotherapist. Actually, the referral don't just cover the 2 health problems you mentioned. So Dr. Pan can explain. And also, we also allow optometrists to take part in primary healthcare. As for elderly healthcare voucher, the Deputy Secretary can answer. Dr. Pan, we do want to, through various channels, and communicate with Hong Kong Physiotherapists Union and Society and to obtain their viewpoints. Under the passage of the Allied Health Services Ordinance, we need to discuss with the sector's various criteria because we're talking about multidisciplinary collaboration. The views of various sectors would be very useful for our formulation of guidelines because we need to carry out changes by stages and in an orderly manner. And it's not that we want to limit the coverage to osteoarthritis of knee and low back pain, but we'll just begin with the most common problems only. We want to reach a consensus with the sector as well. for each discipline, they cannot just operate in silo. There must be referrals. So we need to have a consensus in multidisciplinary collaboration. And after the passage of ordinance, we issue the first guideline. After discussions with the sector, we'll continue to have review. And secondly, new issues have arisen, and the relevant management committee has laid down the various first contact physiotherapists arrangement, and the training of first contact physiotherapists are related to our guidelines. The pace of training and the time needed for training is also of concern to us, and because of the new requirements, the management committee asked for clinical records and appropriate documentation. And this time, and also in today's age, we need to enhance the e-health system as well to include all those records. And for cross-disciplinary referrals, we need to have exchange of information between Chinese medicine practitioners and Western doctors before referrals by physiotherapists can be made. So there needs to be synergy. So we do need to carry out the reform by stages and in an orderly manner. So we'll continue communication with the sectors. On elderly healthcare voucher, in the past, we tried to optimize the voucher scheme. But because we are using public money, we need to ensure that there is a mechanism in place to ensure that the welfare and interests of the elderly people are ensured. As for pharmacists, I think there's an opportunity before us. We are thinking that is when we promote the community pharmacy program, we will consider the applicability of elderly healthcare voucher scheme. When we have more details, we'll share them with you. Next one is Duncan Chiu. I do support primary healthcare services in rehabilitation and triage and treatment of diseases. They play an important role. And to have holistic health for everyone, we do support the use of technology. So on eHealth Plus, primary healthcare is an important entry point and can provide lots of data. People keep asking me HA-Go and difference between HA-Go and E Plus Health. I think you can add more functions to HA-Go, then you can differentiate between the two. As mentioned in the paper, you can provide one-stop service. And so existing and future or existing services can be incorporated into eHealth Plus to provide one-stop service for all. And people also ask us how we can connect eHealth with privately run healthcare app. I know that one healthcare app has been incorporated into eHealth already. I hope that more private services can be incorporated into eHealth. And many welfare organizations also want to have sharing of data with eHealth. So would that be included in your next stage of development? That is to connect eHealth with data or sharing of data between eHealth and NGOs. As for Chinese medicine, application of technology can benefit the administration of Chinese medicine petitioning or the prescriptions of Chinese medicine. How should people, what considerations people should have when consuming Chinese medicine and combining their use with Western medicine? Maybe you can incorporate those information in your next stage of development for eHealth. Your views are noted. If we were to include Chinese medicine in relation to the development of eHealth, I think there's room for further development. ADD can supplement. In terms of applying technology and particularly in relation to eHealth Plus, as mentioned in the paper, I want to highlight one point. That is in paragraph 50, we say that on the eHealth platform, we are building a strategic health service operation platform. And that's in response to what you just said. eHealth Plus often refers to the sharing of e-health records, medical records. But should we continue to develop subsidized services, then with private doctors or even dentists, Chinese medicine practitioners, we need to have connection with their systems. So in the future, this platform will be cross disciplines, covering not just health records, but also the transactions, details of transactions, and also the co-payment amount in each transaction, subsidy amount, and also follow-up treatment for each transaction. Technically, we need to make sure that our system can be connected with the desktop systems of the other service providers. Ultimately, we want to create this platform and try to avoid double entries. So hopefully through this platform, we can provide more convenient access to information. Next one. Chen Hoyan. All along, I very much support a primary healthcare development and also early prevention and early treatment. That's the right direction. But I also want to ask a core practical question. Money and people. In the paper, it's mentioned that the co-care network in the first 5 years, it has a target of 700,000 with a budget of $2.5 billion. That is in a 5-year period. Each person only have access to $3,500. That is, each year is about $700 for each person. So now, for every follow-up consultation is about $196. So that is what you're paying from the public coffers will only be enough for 4 times of follow-up medical visits. I'm just a bit worried. Besides the increase in medical expenses, so the public will need to save money to pay for additional expenses. And for chronic diseases like diabetes or high blood pressure, a few times of medical consultation is not enough. So the administration, how can ensure that the public can spend within limits and that the costs are affordable to them? And you're proposing that private doctors charge $150. Can you offer any mechanism to stop private doctors from increasing their medical fees? And in the 5-year period, it's natural for them to increase their fees. So how can you set a ceiling to the payment?
And you have been emphasizing the whole person health and primary health care, but you have neglected dental services. Now, apart from the primary school children, from secondary school onwards to adulthood, you have not sufficiently included dental service. So what will you do there? And the third question, we need private doctors to participate in the scheme so that you can meet your target of 700,000 treated. But you see that the private doctors are saying that the participation urge is not strong because it is not transparent and the process is complex. So how can we encourage more private doctors to participate in the scheme? Will you be regularly reviewing your subsidy level, that you raise it from time to time? And also another question concerning physiotherapy. Actually, in their submission from the physiotherapists, it is very clear. It seems that you're overly focused on lower back pain and also degeneration of joints. So when will you be going back to the focus of overall musculoskeletal diseases? Now, a few questions there. First of all, for the people of Hong Kong, how they can co-pay effectively. Well, for the model that we are adopting, it is a co-care network for primary health care. And there is a concept of co-payment therein. So as I've mentioned, we want those who are able to pay, to co-pay. So we will be considering the affordability for the people, but there are the underprivileged who cannot afford it. So therefore, at the DHCs, where staff have identified them, they will be referred to the Health Department Family Medicine Outpatient Service. So they will still be able to get the screening services such as women cancer screening, 3-high screening services that they get otherwise. So they do not have to fear that because they do not have the finances that they do not get the service because they cannot co-pay. Your second question concerning expenses, it would include screening, management, and also supplemental services and a small amount of administration costs. And it is not like you can just divide them with a certain formula. But as I've mentioned before, there is a co-payment element in it. And in the register, there are 4,000 medical doctors who have registered. Let's say for vaccination participation, there are 2,000 doctors registered. For chronic disease management, there are 800 doctors registered. We want there to be more, of course, but as Ms. Chan mentioned, yes, we very much value their input as well, the doctor's input. Chairman, she has not answered my question at all. I'm saying, how can you set a ceiling for citizens' co-payment? I mean, the private doctors can raise their fees, right? And as for the formula, for 5 years, 700,000 people, 2.5 billion. So for each year, it is $714 for each patient. So what I'm asking is, what would the citizen have to pay in the future? It's $150 for consultation tops for you now, but the private doctors can raise their fees. So is there a ceiling? Well, let me just explain the design for co-payment. Yes, my colleague will answer that question. First of all, the underprivileged sector is a focus of ours for serving. So for the family medical consultation, we will be developing with efforts, focus, the screening service. So that is not included in the 2.5 billion expenses. So that's the first question for you. Yes, there will be further investment for the underprivileged sector. Now, for those who can afford, for the sector who can afford it, we have talked to the industry and profession. They want us to have more transparency to disclose the co-payment amount with vis-a-vis the patients. Now, some 60 to 70% of the doctors said it under $150, so more or less at $100 for co-payment. But we can look at the operation to see for co-payment, how can we be able to meet our original intent for the scheme. Now, for the co-care network, after it had been formed, we will continue to monitor and review the subsidy for it. At present, we have some new subsidies for the network, and when the network is complete, we will be holistically reviewing the subsidy scheme. Yes, this is public expenses, public funds. We have to be very cautious, and in reviewing the subsidy, we'll be very cautious and adhere to the principle of public funding usage. Now, for the citizens, they are the first line of responsibility for their own health. So for prevention, how do we invest in it, and how much should the citizen themselves be co-paying or taking up responsibility? That is something we have to focus on. 2.5 billion we think is sufficient. Why? Because let's say for hepatitis B at the second year, after the situation of the disease had stabilized, the patient doesn't have to go to the doctor overly regularly or all the time. So on average 4 times. So of course for different diseases there are different frequency and expenses, but of course we will be reviewing the responses from the citizens after it had been launched in full. And overall speaking 4 times, also for women health screening as well. So that is by way of answer. Yes, if you can be more brief. Yes, going to the doctor for consultation, 1 patient, 2 patients is the same fee. So why would he want to save anything? Yes, Chong Ho Feng. Yes, I can see that the government had done a lot in recent years in primary healthcare, but especially in chronic diseases and women diseases or women health, but there is no mention of men or male health. So what are your plans for male health? For primary health care, what can be provided there? In paragraph 18 of your paper, you have talked about the women health needs and also co-payment for vaccination services and also mammograms and also HPV vaccines, etc. This not only applies to women. Men should also go for HPV vaccination. In Taiwan, it is provided, for example. But here in Hong Kong, we do not have men or male students subsidized schemes. Would you be considering a pilot scheme in the schools or perhaps do more education and promotion in the centers so that the women who go there would bring the education and information back to their male relatives, husbands, sons, etc.? Right. Let us explain more clearly concerning these services and also school children vaccination. And we actually have a committee to give us advice, and we refer to those opinions as well. Dr. Pang will answer the questions. Yes, male health is also something within our realm of risk-based service. And there are very few diseases which are specific to male only. But of course, we'll be talking to the professionals to see whether there are certain diseases which are directly related to male. Yes, for certain chronic diseases, which we believe are more related to male in the future, we will be focusing our services more on men. As for the HPV vaccine in Hong Kong, we need the health department to formulate policies before we can do so. And we know the scientific committee will be discussing the HPV vaccine, and we will come back after there are results. Well, actually, there can be unsubsidized vaccination for HPV if the people themselves believe so and want to have that vaccination. Yes, Chairman Yan, paragraph 27 of the paper, you see as of January of this year, there are 520,000 cumulative year-on-year membership for the DHCs, and with cumulative number of attendees reaching 3.89 million. So that's 7.4 visits per person. So is this reaching your target? And is this service sustainable? And also, do you have data from the different districts so that in resource allocation it can be more evenly distributed, and also accessibility of medicine. Actually, we had a roundtable at my organization bringing different thoughts together. In paragraph 46 of your paper, you say that 100 drugs are included in the formulary, and it will be increased to 400 in the future. So for the renewal frequency, what is that, please, for the list? And also accessibility of drugs, how many tens of thousands of our citizens, matching that to the number of pharmacy, what is the ratio, please? And for certain housing estates where there are no Western medicine doctors, will you be filling that gap? And also, will you have smart pharmacy so as to increase the transparency of drug pricing and also for referral or reference concerning drugs? And will you be considering that from the patient's point of view? Thank you for the questions. In our development for primary health care, we are increasing our service gradually. Now, concerning community care, Dr. Pang will answer the question. Concerning formulary and pharmacies, Dr. Zheng will answer that question. Thank you for the question. For community health, since the first center had been completed in 2019, there had been more and more such hubs or centers set up. So this 3 million is cumulative for all the DHCs concerned because they were commenced at different years. So we have used the cumulative method for calculating. The 7 times should be divided by 3 to 4 years. So for each citizen, it would be per year 2 to 3 visits per year. So this is reasonable for us at present, and we will continue to monitor the situation to see whether there are certain services which needs increased efforts, and we will try to see how we can have more services. For example, strategic purchases may be one for the community.
Dr. Zheng, the community drug formulary announced last October its mechanism, and the paper can be uploaded or downloaded from the PHC Commission website. The list of the community drug formulary is still being compiled. We hope that the list can be publicized by the end of this year. Second half of this year. Initially, there will be more than 100 drugs being covered, but the number will increase year by year. And this will be updated regularly on the website, telling the public about the various tiers of drugs available. The whole mechanism will be updated every year if needed. We can also have updating or upgrading more frequently and see we need to enrich the formulary to meet the needs of the public. We hope that the experts at the PHC Commission can actually consider the coverage of our services and suggest to us how we can add more drugs or new drugs to our formulary. How about locations? Considerations for locations? Undersecretary? Any supplement? In the 18 districts, across the districts, in each district, there will be, during the promotional period, we'll have a maximum of 5 pharmacies. After the pilot scheme ends, if we find that more pharmacies can be offered, and we will increase the number. I know there will be pharmacies in each district, but would you look at the distribution of population in various districts? And also, would you consider in districts without any Western doctors provide more community pharmacies? We'll continue to make references and see how the community pharmacies keep being prepared. And, of course, theoretically speaking, the more pharmacies, the better. For estates or districts without doctors, or estates without doctors, then you can discuss with NGOs, see where they can provide services there. The last one is myself. We won't have a second round of questioning. My first question is, the paper mentions the concept of DHCs as an entry point for provision of services and matching with family doctors. I'd like to confirm with you, your initial design is for someone with a family doctor already, so people can go straight to the family doctor to confirm the doctors as their family service providers, right? And also members suggested that, or Young Wing Kit suggested that the community dental assistance program its scope is very limited. So would you increase its service points? Besides NGOs, would you open the program to dentals who are willing to join the scheme? Okay, I'm not going to ask any questions about community pharmacies because you've answered that. So I'll ask my colleague to respond briefly. Yes, DHCs, they are a area for providing unified services, but they need to collaborate with family doctors because family doctors would like to procure other services to help patients. So DHCs are really an entry point. How about dental assistance program? Well, dental groups have contacted us and told us the same opinion that, well, as I respond to them, when we expand this program, we will not rule out considering various options. Now, thank you. Let's move on to the next item, which is report on the new mental health initiatives and work of the Advisory Committee on Mental Health. So may I ask the Secretary to invite the administration to come in? We have with us Under Secretary for Health, Dr. Cecilia Fan, Deputy Secretary for Health, Mr. Eddie Lee, Principal Executive Manager Health, Susan Ip, and also Principal Assistant Secretary of the Education Bureau, Becky Lee, Senior Specialist Educational Psychology Service of the Education Bureau, Ms. Michelle Chan, Assistant Director of Rehab and Med Social Services of Social Welfare Department, Mr. David Ng, and also Department of Health and Health Promotion Branch Head, Dr. Kelly So. Invited to attend to this meeting is Chairman of the Advisory Committee on Mental Health, Dr. Lam Ching Choi, and HA's Chief Manager, Integrated Clinical Services, Dr. Chris Zhang. So members with questions or who want to speak, please press the button. And members of the panel on welfare services are also invited to join the discussion of this item. So may I ask the administration to take us through the paper? Members, Chairman, good morning. Today, on the together with Lam Ching Choi, Chairman of the Advisory Committee on Mental Health, and other colleagues, we'd like to report to the Health Services Panel. The government pays much attention to people's health. Since the establishment in 2017, the ACMH assists the government in formulating mental health policies. And during its fourth term of service, the committee have in-depth discussions on various mental health issues. I'd like to take this opportunity to thank the contributions of the chairman of the committee and its members. The report tabled today lists to you during its fourth term the work of the committee, and for example, it actively assists the government in exploring enhancements to the mental health service model in Hong Kong, and also provide advice on the framework for the stepped care model in relation to early screening, prevention, early identification, and rehab. As the use of screen and social media becomes more popular, the committee also discussed the impact of screen and social media use for children and adolescents, the possible negative mental impact, and they proposed to the government to update its health advice. And They also reviewed the implementation of the three-tier school-based emergency mechanism. And the committee also enhanced community support services and reduce the impact of stigmatization. And the Shall We Talk mental health promotion campaign and the mental health workplace charter will continue to be promoted. And the committee also work on promoting the 1811 mental health support hotline to provide convenient and instant help for the public. At the community level, to provide more support for the public, the committee have actively optimized various community services, including a Healthy Mind pilot project and services for ethnic minorities to strengthen early intervention and timely treatment for mental health issues. In terms of specialized services, the advisory committee also reviewed the HA services and explore how they can effectively follow up on high-risk cases. In relation to the fire at the Wangford Court and the need for referral services, the committee actively set up a working group to coordinate and launch services for the affected families so that the affected victims can receive mental support to go through this difficult time. Chairman and members, we want to create a mental health friendly society. It is a long-term work and will continue to liaise with NGOs, Health Bureau, and the government, and also listen carefully the voices of the community. May I now invite the chairman of the advisory committee to speak and invite members to comment on the report and also other mental health related policies. Dr. Lam, good morning. In the past 2 years, its work done in the past 2 years have been summarized in the report for your reference. In the past 2 years, basically, we focused on consolidating existing work of the committee, particularly how we can do a better job in coordination and consolidate various types of services, and to make sure that more resources can be allocated for prevention. And we have also actively looked at other support measures as mentioned by the Undersecretary during our term. Our most important work is that of formulation of the three-tier, the stepped care model, so that people at different stages of their lives can have early prevention, early treatment, and professional support. As mentioned in the report, the fire in Tai Po, in the wake of it, we adopted that model in providing services. I'll give you more information, details later on. Our committee also set up a working group to, on a continuous basis, deepen the adoption of the stepped care model, whether online or through the use of telephone. We have optimized the telephone hotline, the 1811 hotline, which has 4 new functions. That is, through WhatsApp, the callers can access our counseling staff, and the hotline also supports various languages for the benefits of ethnic minority groups. There can also be appointments made to have conversations with our counselors. There are also extra optional services. And lately, the Social Welfare Department has launched the Open Up instant apps to actually let people in need access the services they need. So whether it's offline, online, we have enhanced the services provided. Going forward, we'll continue to explore. Now, in the virtual world, as more and more adolescents would rather communicate online, we will explore further various types of online services. As you may know, we are very concerned about mental health of children and adolescents. So in 2023, December, since then, through the Education Bureau and Health Bureau and the Social Welfare Department, we have set up the 3-tier school-based emergency mechanism. Our committee has always been concerned about the progress of the implementation of this mechanism. And we need to, after confirming that the mechanism has progressed smoothly, in the December 1st, 2025, we have regularized this implementation of the mechanism, and in 25-26 school year, the mechanism has been expanded to senior primary school levels, senior primary classes. And we also have the Healthy Mind pilot project launched to offer free mental health assessment and follow-up services. And in 2026, the government expanded the service to 9 district health centers. Taking into consideration the George program by the Hong Kong Jockey Club, I think most district health centers now are providing mental health services. I'm sure you're concerned about the Category 5 fire in Taipo. In terms of mental health, what sort of support we are offering to the victims? Let me give you some details here. Basically, we have 2 large-scale services provided. One is the support scheme for victims who've lost family members in the fire. So we have a cross-disciplinary team reaching out to families with lost family members, and we have already providing services for these almost all of such families. And also we have another program helping fire victims who are accommodated in transitional housing. So continuously with the government departments and NGOs, will work closely with them. Our 2 types of services offered to victims of the Taipo fire actually follow the model of what I mentioned, that is the stepped care model, so that we can work together with the victims. And lastly, I'd like to once again thank the work of the advisory committee over the past 4 terms, the professional opinions given to the government. I also like to thank the government bureaus and the departments over our past 4 terms. They collaborated very well with us. I do welcome more comments from members and questions from you all.
We have 9 members who have indicated they want to speak. I will read out their names: Yang Wing Kit, Chen Wing Kwong, Chong Ho Fong, Chan Han Pan, Adrian Ho, Christine Fong, Chan Ho Yan, Chan Pui Leung, David Lam, Grace Chan, and myself. So 9 persons, 4 minutes Q&A. Chair, I'm concerned about cross-departmental collaboration. I do see that there are certain collaboration, and there are some care teams, cross-departmental, who are going up to the living places of some persons. And in particular for the mental health situations, we want to be able to detect them early. I just want to know how the cross-departmental services can early detect such persons who need help and to provide support. Now, secondly, I understand mental health nurses are insufficient in supply, and we want more of such personnel. How can we add more personnel in this regard? I project for 2040, there will be at least 1,200 that is short-handed, meaning we need at least 1,200 more such personnel. So what's your response, please? Yes, thank you very much, Mr. Young, for the questions. For our mental health service, we very much focus on an integrated approach. The Education Department, the Welfare Department, the HA, and also the HHB and other interdepartmental collaboration, as well as NGOs and other service providers and related stakeholders. So Yes, our colleague will be supplementing on this. As for nurses that you have mentioned, we have extended the scope of work so that those who need mental health services, they will be able to get their service. Well, my colleague will supplement at HD. Yes, thank you for the questions. Actually, for our committee, what is very important for our work is to have collaboration so as to provide the service effectively. Let's say, for instance, the students, the EDB is focusing on early detection and also prevention, and also the HD, the hospital authority, and also social welfare department. They're also going into the schools for talks and work. We would want to have interdepartmental collaboration and for the collaboration to be really effective in providing service. Chair, what I'm saying is that we need a database for collaboration. Housing department, for example, they have data showing that there may be certain units with mental health issues. And so through this data, we'll be able to provide timely service. So is there such a database? Let's say, for instance, as I've mentioned, singletons, elderly singletons can be identified by the housing department, and then perhaps the SWD can also match their database, and therefore some cases can be early detected. I just hope that you can early on build this database. Yes, so the various departments' database plus e-health, can you coordinate that? Well, actually, we have commissioned the Hong Kong University to do a detailed comparison. Australia, Canada, Singapore, the UK, they have certain measures. And the immediate recommendation is that there will be a team with different capabilities, and also, so those are, and also collaboration, those are in the short term. In the long term, it also includes data platform, as Mr. Young had mentioned. Next, Chairman Kwong. Chair, I very much commend the mental health initiatives that are put into place. Now, we all agree that for those who are emotionally disturbed, for them to collapse, it actually takes just a second. So the service need to be very timely. So the persons in need do not feel hopeless, that they feel supported on a timely basis. Now, for your hotline for emotional service, how long is the waiting time? And basically, how long does it take to pick up the phones? And for those phones which are lost, that cannot be picked up, will there be a callback service and how long do they have to wait for that call back to come in? Now, for the typo fire victims, for the bereavement counseling and service, I support that. There had been an immediate psychological service provided to the victims, but the bereavement and also the emotional impact for the typo residents will take a long time of support. Now, it is only on the 31st of December this year that the service fees will be waived. But what about the Wangfu Court residents who still need the mental health service after that date, so as to show the continuous care of the government and the public for these residents? First of all, for the hotline 18111, actually starting from December 2023, since its launch, it had been very popular. It is a one-stop hotline, and we have been reviewing this mechanism for those who can get call through and those who cannot call through. Well, we have data, and my colleague will answer in full that question. As for Wangfu Court residents, we have been reviewing the different services and support we provide them, which are more popular, and including free medical services for them. And we continually review the services. Right, concerning the data, yes. Dr. So, please. For the hotline, since its launch in December 2023 to end of February this year, we have handled 261,800 calls and provided support. The system in June of 2025 was enhanced. For the system enhancement, afterwards, the average waiting time is 31 seconds, and the average time of the call is 13 minutes. If the call cannot be put through right away, they can choose to leave a message, voice message, and they can also give indications as to when the callback should be at what hour and time. So cumulatively, there are 1,900 such voice messages, and within 30 minutes we have called back, and it is 13 minutes in terms of the length of the call. The longest was 29 minutes. That's my report. Any follow-up? No follow-up. All right. Next, Mr. Chong Ho Feng. Thank you, Chair. And recently, there had been an annual report for students indicating their social capability, and a number of students have mentioned that they had been cyberbullied and had attempted suicide. It was respectively 1.6% and 1.7%. In the paper, it says that in 2025, December, for example, all secondary schools were given the three-tier emergency model. And to the end of 2024, this has been extended to P4 and P6 students. So for the cyberbully victims and attempted suicides, the incidents, how has it dropped since the launching of this three-tier emergency mechanism? And also, the teachers are burdened as well. The more caring the teacher, the heavier their psychological burden. So what kind of support are you giving to the teachers? Right, Chair, for the EDB will answer these questions. The EDB representative, please. Chair, members, concerning teachers' mental health. We have certain gatekeeper training for them, for teachers. We hope to be able to strengthen their understanding of mental health diseases and therapy, to have more information about these so that there can be early detection, so that they can be more aware of such situations. Apart from that, for teachers' mental health, we have a sunshine hotline where the teachers feel that they have an issue or certain questions. They can call this hotline and they will be able to alleviate their health or mental health situation. So that's for the teachers. As for the students, all along we have been hoping to support the school children in their mental health. We encourage the schools to adopt a whole school approach. So from focus, from selectivity, and from comprehensive service, we want to improve or provide students' mental health service. So we have also a gatekeeper training for students' mental health as well, and also plans for student development. So basically to strengthen their mental health and to also enhance their resilience for the students. That's our work for the students. Do you have numbers, please, for cyber bullied victims and also attempted suicides among students? Do you see any drop in the incidence? We have been putting in efforts to lower the incidence number. So from within school, outside of school, parents and stakeholders, we want to collaborate with them so that there can be cross-disciplinary, cross-professional collaboration to build the safety net for the students. Chair, I want the number. 1.6% and 0.7%. 0.7% for attempted or contemplated suicide. That's too high. I want that to drop down to 0. Even for one person affected in the school, it is already very grave. Well, it seems like they don't have the number. Perhaps you should set a target number. Chen Hanpan? Yes, I very much confirm your good work. The chair is here today and your team, and in Wangford Court you have a lot of support you have given to the residents. I have two questions. First of all, for your care service, you have a tiered approach. It is more specific and more focused with that kind of service. For your Tier 3, the committee says that for the waiting time, in queue time, and also for those who are not coming back for consultation, that they're gone off and not reporting for consultation, repeated consultation. What about those? And we have insufficient beds. People are forced to leave the hospital, and this is a vicious cycle. They go back out into the community, but shortly they come back to the hospital because they're not completely treated. So this is a revolving door going into emergency hospital and being released and coming back again. We should lower these instances. So I think the committee should look into these cases of repeated hospitalization. How many are there such cases? Are there measures that we can have for these cases? A second question for our community. There are more teams going up for home visits, and also the teams are coming into contact with the citizens in the community, including myself. I've come into contact with possible mental health cases. We want to do referrals. But in the process of referral, can you perhaps strengthen the NGOs in the Tier 1 to 2 with the care teams, collaboration, and also for district councillors' officers, so that the entire referral process can be smoother. And perhaps within your committee, you can consider bringing in members who are district councillors or members who are familiar with community work, so that in tiers 1 and 2 there can be seamless coordination with the different communities and districts.
Thank you for your question. Later on, I'll ask a colleague from HA to give you details. I believe some patients voluntarily enter hospital for treatment, but some have their hospitalization being mandatory. But I think my colleague can clarify to you more about the current usage of the services. And also, we can give you details on the follow-up mechanism. And your other question, I will ask Dr. Lam to explain. Dr. Zhang from HA? Dr. Zhang, is it? Thank you, Chairman. Amber, for your question. As for patients who need to be hospitalized, often they are either hospitalized voluntarily or on a mandatory basis. We have cross-disciplinary team, including psychiatrists, nurses, and psychologists working together. On the whole, we would consider the seriousness of the disease to decide how long a person has to be hospitalized. According to our records, there are now 3,700 psychiatric beds under HA, and the occupation rate is about 75%. So unlike non-psychiatric beds, relatively speaking, our occupation rate of our beds is 75%. So depending on the seriousness of the patients, only when their condition becomes stable would we discharge the patients. As for specialized outpatient services, we have a mechanism responsible for that. On the same day, our doctor in charge would look at a patient's records and the seriousness of his disease and the urgency concern to assess whether the patient needs to be on the same day or within the same week come back for follow-up consultation. And our team would track the patient to make sure that they come back for follow-up consultation. Thank you. Dr. Lam, this is how we can provide community service appropriately and have better connections with the community. That's a goal of our committee. Under the step care model, first step and second steps actually are where the community forces are, and therefore we very much hope to integrate more with the community care teams so as to provide relevant mental health first aid courses or training for community care team members. That's one of our goals. Mr. Chan's suggestion that is to have district councillors in our committee. I do welcome that. Chairman, can I have a figure? That is, you said patients are discharged only when their condition is stable. But based on my understanding, a number of patients are discharged and yet have to be sent back again to hospital. Can you provide us with some data? That is about the number of patients who keep going back and out of hospital. The lack of beds in the front line, we all know, we are aware of the shortage of beds. Of course, you said that patients can be discharged when they're stable, but the problem is many ended up having to go back to hospital again following their discharge. I think sometimes psychiatric diseases, they can have relapse. So can HA give us a figure on the readmission rate of psychiatric patients? Next one is Adrian Ho. Thank you, Chairman. I very much support the work of the advisory committee, and I do think that their work is worthy of our recognition. I have two questions. The first is yesterday, when I was having lunch with my colleagues, I was interfered by someone, and my colleagues recognized that that's the same person who caused nuisance at a shopping center. So that reminded me of the mechanism under which patients are discharged with conditions. In the past 5 years, what's the percentage of patients who comply with the conditions, and how many cases are there in which patients who need to be readmitted into hospital after causing risk to the community? And the latest suicide statistics released earlier by university in 2024, suicide rates for those aged under 14 dropped significantly. I think that's because of the enhancement of public awareness and prevention work done within school. But at the same time, suicide rates among males aged 25 or above rose from 15.2 in 2021 to 23% in 2024. The rise is worrying. And in the report, you haven't mentioned the term males. Indeed, male could be under heavy psychological or psychiatric pressure because they're the breadwinner, or they may be affected by changes in the family. So have you been or noticed any worrying trend among males, and have you got any plans to target the issue? Under Secretary, Dr. Lam can supplement the discharge mechanism. Heart patients with tendency for criminal violence, we will consider their living conditions, their use of medicines, and before, under the supervision of the Social Welfare Department, to consider where they can be discharged. Data-wise, the number of patients who are required to be hospitalized, there are 5,000. And under Article 42 for conditional release of patients, there were 402, of which after conditional release, 48 had to be called back to the hospital. Point 2, I'd like to thank Mr. Ho for your comments. You precisely pointed out our pain point. Under the step care model, the needs of various age groups vary. As I talk a lot about the school children, same for elderly people. The society is very much concerned about them. But people working is a group that is difficult for us to reach out to. Well, not just males, but working women as well face a lot of pressure. We are doing some work for them. For example, we have the Mental Health Workplace Charter. In the past 2 policy addresses, there's also the mentioning of how to optimize our work in this regard. Quite a number of organizations are involved. We are covering about 800,000 employees in occupations where there are a lot of male workers like taxi drivers, security guards, and so forth. They face a lot of pressure at work. So under our charter, we have laid down an annual theme for each year, and we also strengthened our work in encouraging organizations to invite employees to join more mental health training so that they can help themselves and people around them. But no matter what, the workplace, this pain point is where we'll enhance our work further. Thank you, Dr. Lam. Because of time, we need to extend our meeting by 15 minutes. 5 other members have asked to speak. Any objection? If not, then I'll extend the meeting by 15 minutes. The next one is Christine Fong, and after she speaks, I'll draw a line. Christine Fong next. Thank you, Chairman, and thank you for the advisory committee, Dr. Lam, and your team for your contributions to promoting mental health. I very much agree that we need to try all means, trying to using various entry points, like in schools, to promote mental health. Personally, on the other hand, I'm concerned about how we can have precise intervention to help high-risk groups. Social Welfare Department and the community care teams are helping with reducing the pressure on people with mental health issues. For people seriously sick, people or with terminal illnesses like cancer, or people with serious health problems, under HA, HA would know who are the high-risk groups. So can you just look at the information or create a better database for SWD or community care teams or district groups, including district councils, so that they can adopt a targeted approach to use drugs or psychiatric health support to help those high-risk individuals? Lately, I found that for some patients who are seriously ill, through exercises like use a heart rolling ball to divert their attention, or Dr. Lam, you can go hiking or motorcycling, right? Would you step strengthen the work in that regard to promote exercising, and also street sleepers. To some extent, they are people with mental diseases. So can we, in a more precise manner, and take the initiative to invite them or make it mandatory for them to, or bring in religious groups, Buddhism, Taoism, etc., to improve their mental health, and also for online security for young people, adolescents, in social media apps. These apps have a big impact on young people's mental health in other countries like Denmark. They even ban the use of mobile phones on campuses among adolescents. And in China, in our nation, children under the age of 8 can only use their mobile phones for 40 minutes per day. We've done so much in promoting mental health, and yet what further plans can we have? And also for animal treatment, there are lots of using animals for treatment, for people who live alone. I've noticed that animal therapy, or the company of animals, can be an ideal solution in terms of tackling mental health issues. So the Bureau or committee, can you share your thoughts on them? And the Secretary, high-risk individuals, I think when they're discharged, the HA will provide precise treatment, and also in the community we can reach out to them as well. Can I ask the Undersecretary to give us more information? Whether for street sleepers we'll reach out to them. I think SWD's Mr. Ng can supplement. As for online security, let me respond. In 2025 October, Department of Health set up a working advisory group on the impact of social media on adolescents, and they will submit the report within this year. And we would take reference from the opinions of the experts in the advisory group. So my colleagues can supplement.
Yes, Chair. Concerning serious patients, for those who are discharged from the hospitals, we will look at their situation to see whether there is a need for discharged planning so that in the community the patient continues to be supported. And just now we have mentioned that there is data sharing. The HA together with the SWD is building a platform for high-risk individuals such as elderly singletons living by themselves, or elderly couples living by themselves, where one has fallen ill, then mentally ill, then the other can also be supported as well. And also pet treatment is also something that we are piloting for chronic diseases and serious illness diseases. Perhaps they can be accompanied by an animal, a pet. Yes, indeed, the pet can be a very good friend of the human. Concerning street sleepers, if I can just supplement, we have at Social Welfare Department a team, and we understand that there's a complex problem, street sleepers, and it has to be interdepartmental in terms of efforts, and we also have NGOs handling these cases. Now, for many of the street sleepers, they have mental illness issues as well, so we have also included a mental health nurse in the team to handle street sleeper cases. That's my supplement. Next, Ms. Chan Ho-yan. First of all, thank you very much, Chairman Lam, for your and your team's work. I have a few questions on the fire victims follow-up and also private public collaboration and school children support. For the fire victims, it's already been mentioned, there are 3 schemes which are directly helping them, and it's in the paper. But this is a particularly big disaster, and the trauma can last a few years, and the victims in their long-term psychological health, even though it's not emerged as problematic, but it may become problematic in the future. So the authorities, the administration of the committee, have you thought of a long-term support scheme with family support, counseling support, and long-term trauma support? Yes, and I'm concerned about children's mental health. Perhaps there is a plan whereby you look at overseas experience in this regard. Chairman Lam, you and your team, will you be protecting the young, the very young, for example, junior primary students, through ordinances to limit the use of electronic screens and media? Or at school, they limit the number or the time of usage. Perhaps you can think of that. And also for 2022, there will be an extension. There had been an extension of that collaborative scheme to the there had been an extension of the scheme to 2028 for mental health and collaboration for mental health medical doctors, that is psychiatrists, and clinical psychologists. Will you be considering extending that particular scheme? Yes. The HA, please. Yes, Chair. For the 5 victims in Wang Fu Court, their mental health situation, it is true. Our frontline staff have been telling me very regularly that the situation will well extend over a year. And it is true, as a first step, for the 2 schemes that we have planned for them, they are going to last for 1 year, but we are already planning for the schemes to be extended further, especially for the bereaved victims, those who have lost family members. Their bereavement, their sadness and pain would be very different, and it would be deeper and complex and more serious. And also the collectivity of the victims, that is, a group of victims, would actually lengthen their bereavement period. So we are cognizant of that, and we are telling the team that we will be doing a review in a few months' time to see how we can extend that service for a longer time. Now, as for the network, as for the young people, the Health Department is preparing or working on a new guidance for us, and our committee will look at the guidance to see whether there are recommendations we can make. We will also look at overseas experience, and we may consider legislation. But according to the guidance when it comes out, we will be consulting widely to empower the schools and also the parents to see how young children can healthily use electronic media. And we are very proactively vis-a-vis the social media platforms. We are proactively communicating with them. We want to collaborate with them. If we do not see any improvement in this situation, well, our committee is open. We will be discussing this, and we will be looking at overseas experience and their efficacy. And we will be proposing to the government as to whether legislation is indeed a way to go. Yes, Dr. Zhang. HA. Right, concerning collaboration, public and private sectors for cases which are stable and which are under treatment, they can continue the treatment in the community. Now, where a patient had been given 12 months of treatment and is in stable situation with only mild depression and mild anxiety, they can continue their treatment in the community by private clinicians for continued support. And the HA will continue to monitor the efficacy to see how we can provide the patients with appropriate service. So you're saying that it will be extended beyond 2028? Because the question is, this is already 2026. Will it extend beyond 2028? Yes, we'll be reviewing the efficacy of the scheme to see whether we want to extend that or whether we want to actually improve on that. Yes, we have 3 more members indicating interest to speak. We will end the meeting after their Q&A. Chen Pulang, yes, first of all, I want to commend the work of the committee and the team. Now, on prevention and promotion, this is very important in terms of mental health, and I see the chapter on this topic is the longest in your report. Now, prevention, there's been a lot of work done in different levels, at different levels and different sectors. Now, for prevention measures and also for promotions, what is the effectiveness of these measures? Yes, we have the hotline, for example, etc. We will be able to know how many calls are taken, but what about the effectiveness of these measures? If we have the effectiveness data, then we will be able to be in the know as to how we can perhaps give more support to the measures which are effective or not so effective. Another question on the Wang Fuk Court residents. Yes, the support will have to be given to them for a period of time. Just now we heard that the support may be extended in time period. And we also know that there are social workers involved, and they are basically giving the closest service to the victims. Now, for these victims who need mental health support, can we also have them connected up to this one household, one social worker scheme or system so that they can be given timely support? Right. For prevention measures efficacy, we have mentioned lightly just now, shortly just now, that the Hong Kong U is conducting a study, and they have indicated that a data platform needs to be built, and where conditions are right, we should look at the efficacy and cost effectiveness of our measures. So this will be in the long term. But at the same time, the health department has a lot of data concerning school children health, and through that we will be able to see the trend or any improvements as well. Yes, as for one household, one social worker, Mr. Chan is correct. It is a best connecting point because for the residents, yes, for many of their everyday life needs, they will go to the social worker as a first point of contact. Yes, and we really very much rely on the social workers' referral as well. So that system has already been built up. The referrals can be made to the different services that we offer. And if at the point of accessing the service, if our staff find that there needs to be other services provided, they will go to the social worker. So the system is actually pretty efficient and working well. Right. First, Grace Chan, I confirm the work of the committee, and the scope of service is wide, and it is a never-ending work. Now, I have certain questions. If you do not have the answers today, that is fine. Again, it is about data. For example, for serving the community with elderly dementia cases, for those who are participating in this scheme where they're identified as high risk, let's say, elderly couple living by themselves, do you have in your database any opportunity for matching so that we can have more comprehensive support? So this is, again, about usage of data. And also, we know that mental health is not to be handled by a single department. It cannot be done like that. So for some emergency cases, let's say, the police, the SWD, and the HA will have to come together. What exactly is the communication system among these, please? We haven't been talking a lot about this, but what is the reporting system so that the different departments can have a good regimented system for collaboration? And lastly, as we all know, there are a lot of organizations which provide mental health surveys. And so
And after the survey on mental health was done in Hong Kong, have you got a timetable to carry out a territory-wide mental health study to get the latest figure on the rate of population with mental health issues? And I think that's a suggestion for you to consider. Okay, data and early identification of high-risk individuals and survey, territorial survey. Data definitely is, what we'll do. That's our direction. As for the mechanism for or emergency cases, well, once we are aware of an emergency case, we will definitely call the police. And as for the yes, as you said, we have carried out studies for individual services, and in 2023, various surveys were done on various groups like children and adolescents, youth and elderly people on their mental health conditions. So in the long run, we'll see whether we can integrate the information and put them on the same platform. In terms of data, we do pay much attention to it. Our report suggests that in the long run, we should create a proper database now with AI, and also we will look at how we can leverage AI. You're all concerned about the safety of the online world, and we are exploring whether virtually through AI we may not get the definite number, at least we can identify the trend. And that's what we'll explore as well. As for a territory-wide survey, as suggested by Ms. Chen, you said it right. We will see in which year we will carry out a follow-up study to let us know for various age groups what are their needs. Last time we didn't cover the age group of the working group, people who are working. So at the right time, we will include them in our survey. Lastly, the last one to speak, as mentioned in the stepped care model, the paper illustrates the goals for each tier, and it seems that for staff deployment, you haven't given us a comprehensive picture. So I'd like to ask for the entire model, well, what are the role of family physicians or specialists as opposed to other family general doctors, and clinical psychologists and occupational therapists in the entire model? What are their roles? Chairman? Thank you, Chairman. And this is exactly what we are concerned about. On one level, we need to know how many such professionals are available, and secondly, their ability. We're concerned about that too. You mentioned, Chairman, like family doctors. We very much want that more family doctors can consult or have contact with patients with mental health issues. Family doctors, maybe through referral from the HCs, have contact with mental health patients. But if it's a solo practice doctor, or how can the public know that these doctors can deal with mental health issues, or the doctor, if whether the doctor themselves are willing to help mental patients. And same for training. How can we train more family doctors with the ability to treat or to identify mental patients? In our tiered mechanism, we will deploy them, CP, OTs, at different levels of our work. No problem with CPs because their profession is to deal with mental patients. As for OTs and other professional workers, we want to adopt a competency-based approach. Whatever professions they are from, as long as they are properly trained, appropriately trained, we want to incorporate them into our stepped model. This is just an initial idea because we only received the report. As for the way forward, our committee will carry out relevant study. As for the various tiers, after tier 3, when the patient is discharged, went back to the community, what tier he will be in? When he goes, that's tier 3. So when he returns to the community, he will drop to tier 2. Okay, now thank you. There's no AOP, so meeting adjourned. Thank you all.